Hello everyone, I am Wenceslao Segers. I am a general doctor from Chile. First of all, I want to apologize myself for my English. I hope you to understand and I will do my best. The topic of this class is going to be about choriamnionitis and ruptures of membranes. We will try to answer the question, it is important to know about these two topics. Thank you, Sebastian, for the invitation and let me be part of this seminar. We know that the majority of you are in a strike, so the idea of this video is that you can see it whenever you want, the times that you want, you can pause it and you can go back the times that you want. Which are the main goals of this class? First of all, to know and use the correct terminology about these two topics. I'm sure that you have heard many times preterm ruptures of membranes, pre-labor ruptures of membranes, premature ruptures of membranes. And the same with choriamnionitis, what it is, intraamniotic infection, intrauterine infection, etc. So we will try to define all these concepts in this presentation. And second, to recognize these two clinical presentations and to manage them adequately. And what we're going to see in this class is a little introduction and the main concepts about ruptures of membranes and also choriamnionitis. Why we decide to talk about this topic? First of all, the PROM, that we will see the definition in a few minutes, is responsible of 1/3 of the preterm birth and is also the most common identifiable factor associated with preterm birth. As we know, the preterm birth is the main cause of perinatal death. So we are in front of the most common factor associated with the most common cause of perinatal death. What about the prevalence? The PROM is around 3% of all the pregnancies, and the choriamnionitis is the same, from 1 to 4% of all the pregnancies. So what happened in the Bagadi hospital? If we attend around 30 deliveries daily and we see more than 50, 60 pregnant women daily, you will see many of these ruptures of membranes and choriamnionitis. So that's the importance that we have to know about this management of these two pathologies. And another important point why we decided to talk about this topic is because the management and the treatment are very controversial in all the world, in many academies and in many countries. To have an expectant management versus when do we have to make an intervention? When do we have to use tocolytics or corticosteroids? When do we have to use antibiotic as prophylaxis or as treatment? And of course, the correct timing of delivery. Those are questions that we will try to answer in this presentation. Also, we will see many news in all around the world, this is our news in the BBC, about maternal death and also perinatal death, caused by severe sepsis or caused by these two causes. So that's why we decided to talk about these two pathologies. We're going to start talking about the ruptures of membranes. Here we have two definitions. First, the pre-labor ruptures of membranes, abbreviated as PROM. So the definition is the membrane rupture before the onset of uterine contractions and cervical effacement and dilation. So it's the same to say the ruptures of the membranes before the onset of the labor. This definition before was known as premature ruptures of membranes, but premature is confusing because it's the same that preterm. And then in the second point we have the second definition, that is preterm pre-labor ruptures of membranes, that is abbreviated as PROM, and it's the same than before, but this situation have to occur before the 37 weeks of gestation. That is the same to say at the preterm labor. What about the pathogenesis? We have to know that there are many schemas, many diagrams, many theories about PROM, PROM, preterm labor, etc. But what does it mean? Probably that is not completely understood. I will try to make a little summary of the pathogenesis. The strength and integrity of the membranes are given by extracellular membrane proteins as collagen, fibronectin, and laminin. These proteins are degraded by matrix metalloproteases, or abbreviated as MMP. And these proteins, this MMP, decrease the strength of the membranes. But there are other proteins called tissue inhibitors of MMPs that maintain the integrity of the membranes. So there's a continued balance between the inhibitors of the MMPs and the MMPs. And there are some situations that increase the number of the metalloproteases. As bleeding, we will see that the abruption placenta is a risk factor. The mechanical stress, that's why we don't recommend, for example, to a pregnant woman to run a marathon. The inflammation with the tobacco, for example, and also subclinical infection, we will see that the colonization of bacteria is also a risk factor to have a rupture of membranes. So here we have the list of many risk factors. As in many situations in gynae, to have a previous episode is a risk factor for have a new episode in this new pregnancy. And this is not the exception. To have a previous pregnancy with ruptures of membranes, it is the main risk factor to have another ruptures of membranes in this pregnancy. Also, genital tract infection as STIs, as urinary tract infection, also antepartum bleeding as abruption placenta, as I said to you. Cigarette smoking producing inflammation, trauma, intrauterine devices, and cervical incompetence are another risk factors. And in the last square, we will see that all the situations that produce distension of the abdomen will be a risk factor for have a ruptures of membranes, as polyhydramnios, as have a a twin pregnancy, and also macrosomy. So, which are the clinical findings about the ruptures of membranes? In the majority of the cases, we will see that the pregnant woman come telling us the history that they were in their houses, they were sleeping sometimes, and they suddenly present a gush of fluid from the vagina, more known as the water breaking, that also soaks through the clothes. So in that case, it is very easy to make the diagnosis. They will tell us also that it's like to make pee, but they cannot control it. It's very easy to make the diagnosis, but sometimes the leaking is only with just a small amount of fluid, either continuously or intermittently. And sometimes even it's just the sensation of an abnormal wetness of the vaginal perineum. So, in those two last questions are the importance to make the specific diagnosis. In the physical examination, when the patient comes without having an active labor, we must do a sterile speculum. There we can see the amniotic fluid leaking from the cervical os, or also we can see a pooling in the vaginal posterior fornix. If we don't see clearly, we can ask for the patient to push or to make valsalva or just to cough. And these maneuvers provoke the leakage of amniotic fluid. In these cases, we have the diagnosis made. It's pathognomonic of ruptures of membranes. In the speculum, we also can see cervical modifications, and rarely, I have never seen one, prolapse of a fetal part or prolapse of the umbilical cord. Those are different situations, and we would be in an emergency. Why in this corner I put it a vaginal examination? I invite you to put pause in the video and try to answer. I'm sure that you could figure it out that the digital examination, the VE, should be avoided. It's forbidden because it increases the risk of intrauterine infection. So we have seen the history, the physical examination. We are going to talk about the laboratory request and the ultrasonography. If we still have doubts with the diagnosis of the ruptures of membranes, we can make an ultrasonography. Here we will find oligohydroamnios, defined as the maximum vertical pocket, or MVP, of amniotic fluid, less or under 2 centimeters. Also can be defined as the amniotic fluid index, or AFI, under 5 centimeters. The ultrasonography will also provide additional information about the fetal status. So, in all the academies, they recommend to do an ultrasonography. In the laboratory test, this is very important because the hematology and chemistry tests are normal in the abscess or infection. We will see that one of the most important pillars of the treatment is the monitorization. So, if we see changes in the laboratory, it could also be caused by an infection. So that's the importance to ask for laboratory requests. In the diagnosis, we have first of all the physical examination, that, as I said, is the direct observation of the leaking of fluid or the pooling fluid in the vaginal posterior fornix. If we have doubts, we have to ask for an ultrasound, where we can find oligohydramnios. But if we still having doubts, there are some amniotic fluid tests and laboratory tests that they will allow us to have evidence of the ruptures of. First exists the commercial test. There are two. In the first one, we will see the placental alpha microglobulin 1 protein assay, more known as amnisure. It's not necessary to know which protein we are looking for, but it's very simple. As we can see in the image, we have to collect the sample, then to transfer to a solvent, then to insert a test strip. Is the same that we do for the pregnancy test or the urine dipstick, and then we have to read the results. If the results, as in the 4 images, we see 2 sticks, it is positive, and it means that the secretion that we collect the sample have this protein that is coming from the amniotic fluid. Also, we have another kit, another test called where we look the insulin-like growth factor binding protein 1, but it's better the amnisure. Also, we have the nitrazine paper test, where we will see the pH of the secretion. As we know, the vaginal pH, the normal vaginal pH, is around 4, from 3.8 to 4.2. So, if the baby lives in an environment with that acid fluid, the baby probably will die very soon. So the amniotic fluid is neutral, is more basic, so it's around 7 and 7.3. So if we see the pH of the amniotic fluid of the secretion, and it is amniotic fluid, we will see that the pH is going to be around 7 and 7.3 and not 3.8 or 4.2. The other test is the Fern test, that is just to see the secretion in the microscope. We will see an arborization or ferning, that's why the name, a ferning pattern. So the ferning pattern is because we are seeing the amniotic fluid in the microscope. In this slide, I want to make a fast quiz. It's like a break. So I want to ask you, which is the capital of Chile? To know if you remember or you just know something about my country. In the image, we can see the Los Andes chain mountains, and also we can see the tallest building in all South America. So pause the video and you will have like 5 seconds to think in the capital of Chile. You remember? It is Santiago de Chile. Sebastian and me, we are from Chile. We also came from Santiago, the capital. So we will continue. So we have seen many things about the ruptures of membranes, the definitions, the pathogenesis, the risk factor, and the clinical findings, and how to make the diagnosis. Now we're going to talk about the management. And as I told you, this is very controversial. It's controversial because we have to know when we have to act or when do we have to just to wait and to see what happened. When do we have to use tocolytics? How much time we will have to use the antibiotics? The timing of the administration of the corticosteroids. Methods of testing for maternal fetal infection. And as I told you, the most important question is when is the correct time of delivery. So, which are the general principles of management? First, we have to ask for a full history and physical examination of the patient. Then, to request the laboratory test, ultrasound, and if we still have doubts of the diagnosis, to ask for a specific test. That will allow us to have an accurate diagnosis. The second principle is the teamwork. We always have to remember the teamwork. We have help in the hospital, we can ask for help to the nurses, to the doctors, to the clinical officers, to everyone. And the third pillar of the management is the continuous monitorization. It is very important because any change could be another treatment. So that's very important to be continuously monitoring the patient. We will divide the treatment after the viability, the fetal viability, between 23 weeks and 34 weeks, and after 34 weeks and under 37 weeks. We're going to see the preterm, pre-labor ruptures of membranes. We divided the 34 weeks because we're still having this week as the limit of giving or not corticosteroids. But we will see the different management. So first, over 34 weeks and under 37, the management of the ruptures of membranes is the delivery. Okay, we have to think immediately in this patient have to deliver now. The way of delivery is controversial, but it is the normal delivery, the vaginal spontaneous delivery, which is recommended. The cesarean will be recommended just in the standard indications. If we don't have, the spontaneous vaginal delivery is recommended. We will see in the Varadi hospital that many patients they don't have as a safe gestational age. So they have, like, I don't know, an ultrasound in the 30 weeks of pregnancy. So we have a period of time where we have doubts of the gestational age. So in those cases, the correct management will be to be expectant and to wait until 36 to 37 weeks. So it is important to know this because if we don't know exactly the gestational age, we have to wait until the ultrasound shows us the 37 weeks, not 34. Between 23 and 34 weeks, the correct management is to have expectant management. So here we don't have to deliver the baby. Here we have to give corticosteroids, we have to give antibiotics, and it's very important to hospitalize this patient during all the period until the delivery. So, which are the ideas of the corticosteroids? The corticosteroids will reduce the morbidity and mortality of the prematurity if preterm delivery occurs. It takes around 2 days for make a correct action. The prophylactic antibiotics, the recommendations are ampicillin and erythromycin. Why erythromycin? Because the erythromycin is not just an antibiotic that we use against the bacteria. It also increases the latency of the delivery. So the erythromycin increases the period from the ruptures of membranes to the delivery. And the fourth pillar is the hospitalization. Remember, always you have to hospitalize the patient until the delivery. we have to use tocolytics? Yes or no? Well, the answer is yes, but the correct use of the tocolytics is not because themselves have a good action for the baby or for the mother. They will just delay the delivery 2 days, 48 hours for allow the action of the corticosteroids. So the main objective of the tocolytics is to wait until the action of corticosteroids. But we have many contraindications of the tocolytics. First, we can't give tocolytics in advanced labor when the dilation is over 4 centimeters in the second phase of latent period. Also, it's totally forbidden to give tocolytics in chorioamnionitis or in any infection after 48 hours of ruptures of membrane, because of the probability to have colonization and subclinical infection because of the period of ruptures of membranes. Also, it is contraindicated in non-reassurement fetal status, in abruptio placenta, and also in risk of cord prolapse as malpresentations or the dilation of the cervix. When do we have to interrupt? This question was another of the controversial points. So we have to have an expectant management until some of these points occur where we are going to interrupt the delivery. So the first is intrauterine infection. That's why it is very important to make continuously monitorization of the patient and also with laboratory requests. If we have also abruptio placenta, we have to deliver and interrupt immediately. When we have non-reassuring fetal status, and also when we have high risk of cord prolapse. So are the same situation that we saw in this previous slide, that was contraindications of the tocolytics. In these situations, we have to interrupt the pregnancy. Of course, that we want to have the 48 hours to make the corticosteroids produce their action. So, fast quiz, the second fast quiz of the class. Which is the most recommendable antibiotic prophylaxis for the stable patient with preterm pre-labor ruptures of membranes? So, pause the video again and you have to think. As we said, this answer is very easy. It's not the letter A, it's not the letter C, and it's neither the letter D. It is the letter B, ampicillin erythromycin. We will cover with these two antibiotics a wide spectrum, and also the erythromycin increase the latency period. We will continue with chorioamnionitis. So, first we are going to talk about the definitions. Chorioamnionitis is the same than intraamniotic infection. We have heard about it, or is the same that III, intrauterine infection or inflammation? The answer is yes. They are the same, and we're going to use it as synonyms. The III is not well known, but some academies use it, so that's why I put it here. The definition is the acute inflammation of the membranes and chorion of the placenta. That's why some academies say that the correct word is to use intraamniotic infection, because it's not just the chorion or the amnios that is infected, it's all the amniotic cavity. The incidence, as we saw in the beginning of this presentation, is around 3% of deliveries overall, and 40 to 70% among pregnancies delivered preterm because of preterm labor, PROM. So it's important to know it. Again, about the pathogenesis, we will see that the most common pathway to have an intraamniotic infection is the ascension. That means that the cervicovaginal flora will go up through the cervical canal until reach the amniotic cavity. There are other pathways, like Listeria monocytogenes is a bacteria that usually use the maternal bacteremia to infect the amniotic and the placenta. Also, this pathway is used by the Streptococcus, the Staphylococcus aureus. When we have skin infection and we have bacteremias, the Staphylococcus usually, or not usually, but can infect also the placenta. And the third pathway, that is not also very common, is from contamination of the amniotic cavity as a result of an invasive procedure, like an amniocentesis. I didn't talk about amniocentesis and other invasive tests to make the diagnosis of the ruptures of membranes because they have been replaced by the non-invasive tests like the Amnisure, the Nitrazine test, the Fern test, etc. So that's why I didn't want to talk about the amniocentesis and the invasive procedures. So what about the microbiology? We have to always remember that this is polymicrobial. That means that we will have to use a wide spectrum of antibiotics. Non-polymicrobial we will see in the hematogen transmission, as Listeria, as Staphylococcus aureus, etc. So the most common bacteria that are isolated in the chorioamnionitis is genital mycoplasmas, like ureaplasmas and mycoplasma species. And we also will find anaerobious, enteric, gram-negative bacilli, or GBS, group B streptococcus. Which are the risk factors of the chorioamnionitis? We have two main risk factors. First, the long labor, and second, the long ruptures of membranes. That's why we include this chapter into the ruptures of membranes. But we have many other risk factors, like to make a multiple BEs in a patient. It's recommended to remind that we always have to maintain the sterility of the glove, because it's not the same to make multiple BEs with a non-sterile glove than to make multiple BEs with a sterile glove. Also, the cervical insufficiency, the nulliparity, STIs or UTIs, also the alcohol and tobacco, and as in all the situations in gynonops, to have a previous intraamniotic infection, or also to make the internal uterine monitoring, but here in Bagadi we will not see it. So which are the clinical findings now in the chorioamnionitis? First of all, we have to always remember that we have always fever. 100% of the cases we will present with fever. Also, we will see maternal leukocytosis, well known as over 15,000 of leukocytes. We will find tachycardia, maternal, over 100, and fetal, over 160. We will find uterine tenderness. We will find bacteremia, not in many cases, just when we will have Listeria, Staphylo, and other bacteria. And also, we can find purulent or malodorous amniotic fluid. We will see in a few slides that there are some criteria called Gibbs criteria. And we can make the diagnosis just with clinical findings. So, if with the clinic we suspect chorioamnionitis, we will have to make the diagnosis. So, we will have to ask for at least a full hemogram, urinalysis, and urine culture. But if the mother presents with sepsis or she presents with shock septic, we will have to request of all the exam battery of the sepsis and shock, the classes that we have seen in a few weeks ago. So the third step to make the diagnostic evaluation is the evaluation of the amniotic fluid that will confirm or exclude the diagnosis. It is when we still have doubts with the clinical findings and we want to confirm the diagnosis, we can make, for example, an amniocentesis, or where we can make a gram stain, so we can make a culture, we can see it in the microscope, the amniotic fluid, but it is not in the Bagadi hospital, so we will not see it deeply. As I said, for make the diagnosis, we have criteria called Gibbs criteria. This is the Lord Gibbs. I don't know him. So the first criteria, as I told you, is fever. Fever is always present, and here it's defined as one episode over 39 degrees or 2 times between 38 and 39 degrees Celsius. And fever have to be with 2 or more of the following criteria: the fetal tachycardia, the maternal tachycardia, leukocytosis, uterine tenderness, purulent appearing fluid, increase the contractility of the uterus. So we will have fever plus 2 or more of the other criteria. If we have this, we have the diagnosis of chorioamnionitis. We will see in Bagadi Hospital this is very common for many patients to have leukocytosis will be the exclusive criteria for having a chorioamnionitis. But these are the real criteria to define chorioamnionitis. So it is very important to manage them. So talking about management, there are 2 pillars. In the chorioamnionitis, we have to interrupt immediately. So the first pillar is to have the delivery. And the second pillar, or the second big area, is the antibiotic, but now as therapy, not prophylaxis. So the schema will change. If we have the spontaneous vaginal disease, we can give ampicillin gentamicin. This is a wide spectrum, and here we will not need the increases of the period of the latent period as erythromycin. So we will use gentamicin. And if we have to do a C-section, we have to add metronidazole, okay, for cover the anaerobes. So to remember, the management of the chorioamnionitis is the delivery and the antibiotic therapy. Which are the adversal neonatal outcomes, and why is this so important to treat and to have an accurate diagnosis? It is because the newborns can have, after a chorioamnionitis, perinatal death, asphyxia, early onset of neonatal sepsis, septic shock, pneumonia, meningitis, intravascular hemorrhage, cerebral white matter damage produces for the asphyxia, long-term neurodevelopment disability as cerebral palsy, and all the morbidity related to the preterm birth. So that is the reason why it is very important to have an accurate diagnosis and to treat at time the chorioamnionitis. So I hope that for you to know this concept, the little golden potatoes, Sebastian usually explains them in his classes. So the little golden potatoes are the main concepts that I want for you to remember forever of these classes. The first is, as I told you, the accurate diagnosis, the teamwork, and the continuous monitorization is the key for have a good management and to prevent preterm deliveries and perinatal death. And also, in the chorioamnionitis, once we recognize the Gibbs criteria, we must run, okay? And the 2 pillars, remember, delivery and antibiotics. And for finishing the class, we have the last fast quiz. That is, do we achieve our goals? Yes or no? To remind you, the goals in the beginning of the class were to know and use the correct terminology about these 2 topics, to know the difference between PROM, PROM, premature ruptures of membranes, etc. And also in chorioamnionitis to know that if there are some different definitions, to know if there are some difference between chorioamnionitis, intraamniotic infection, intrauterine inflammation or infection, etc. And the second main goal was to recognize these 2 clinical presentations and to manage them adequately. So if you feel prepared to make a complete history, physical examination, to ask for the laboratory test or the ultrasound, and to make the specific diagnosis and treatment, I am very happy if you learn how to do all of that. So the alternatives are yes at all, I learned everything, no, I didn't understand nothing, and it's the worst class that I've ever seen, and C, partially could be better. So pause the video, be sincere with yourself, and answer the question. I hope that you answered the letter A, sorry. And for me, I achieved my goals, so I hope that you too. And so we have finished our class about chorioamnionitis and ruptures of membranes. I hope you to learn all this topic and for the future to be prepared to receive these two situations. See you the next time. Thank you for everything, and we will be in touch.